Welcome, everyone. We're so glad to see you. We are the Sugar Queens, and we'd like to welcome all of you to this month's social media event. For those who have been following us, you know, for the past 7 months, we have discussing anything related to CGM and clinical practice. We're using our real life cases to demonstrate the benefits of CGM for clinicians, patients, and their families. But this month, we won't be discussing a patient case. Instead, we will be tackling a very important topic, and that is how we can get this valuable technology into the hands of all of those with diabetes who could benefit from this technology. I am Dr. Eden Miller, an osteopathic board family practitioner. I'm a diabetologist and obesity medicine specialist in Bend, Oregon. Today, Jen is unable to join us today. Our thoughts and prayers are with us, but my queen bee, Davida, is here. Davida.
So I'm Davida Kruger. I'm a certified nurse practitioner in Detroit, Michigan. I'm really excited today about our topic of disparities in CGM. And as we researched it, it actually made me think more of how I practice and the things that I too may be missing. So I'm hoping that as this wonderful group is listening to us, that they go back and think of the things that they're doing in their clinical practice that they may share or change that enhances and allows more people to benefit from CGM.
Hey, Davida, I'm so glad you teed it up like that because we're going to get started. And I really want to ask our listeners that are watching today to think about this question that you see on the screen right now, right? We never want to have barriers, but it's important that if we do have these even unrecognized barriers, for us to identify them. And that question, I just want to pause for us to think is a person with diabetes more or less likely to be prescribed a CGM based on their age, their race, where they live, or even like their ability to pay? So, Davida, you live in Detroit. What do you see there? What's that data where people live and it's a factor of how they get CGM? Will you go through that with us?
Yeah, Jen did a lot of good review for us in terms of what is actually out there and what we know about this data. And the fact is that young people are more likely to get CGMs than older people with diabetes. But, and I did the clinical research, we've shown and discussed in our previous social media, older individuals can very successfully use CGM and diabetes technology. I always tell people, and I have people in their 80s that use this. I have people in their 90s. I have a 96-year-old woman who's on a sensor and a CGM. But there are racial and ethnic disparities affecting access to and use of CGM. A study published in Diabetes Care found that non-Hispanic white children with type 1 diabetes were more likely to initiate and continue using CGMs compared to our non-Hispanic, Black, and Hispanic children, which until you read something like that, it just doesn't resonate enough with each of us. We know how lower socioeconomic status is associated with reduced access to CGM technology, which also blows my mind because at least in the state of Michigan, our Medicaids are very generous with our patients if we can reach out, bring them in, and get them started. And then the American Diabetes Association released a study examining barriers to CGM access, noting that individuals from medically underserved communities, low-income areas, and people of color are less likely to use CGMs. The study emphasizes the need to address these disparities to improve diabetes care, but I would say that it isn't just in medically underserved communities. I bet you that it's in my community, it's in all communities, and we need to really step up and take a look at this as healthcare providers.
You're right. Unfortunately, these disparities exist. You know, you're discussing this, bringing it top of mind for me. I remembered that last year I was honored to help ring the bell for NASDAQ. And when I was there, I met the type 1 camper of the year, which was so great. He was the most sweetest, delightful 16-year-old male. He was African American. He was from an inner city. And he and I, because you know I have diabetes, were commiserating a bit. We were sitting there having breakfast. I pull out my pump and my sensor, and he pulls out his finger sticker and his injections. And I said to him, are you not using a sensor? Almost shocked, right? Like everybody with type 1 should be on it. And he said to me, and it broke my heart, that he had not been offered this technology. Now, I didn't go any deeper because I didn't want to make him feel bad, but it just really makes me realize that we got to spend time on this. So for the next few minutes, we're going to dig deeper into the data. And more importantly, we're going to talk about solutions that we can maybe identify these barriers and start to overcome them. So, you know, it isn't any surprise that the most common comment or question we get regarding kind of the barriers for CGM is cost. So let's take a moment and look at that question. Which type of health insurance coverage make a person with diabetes more or less likely to access CGM? So, Davida, give me your thoughts on this top of like.
So, you know, my first thought is that they all cover it. And I really think that that's a very broad comment, but I really believe that to some degree, to some extent, every insurance company will cover it. What you have to determine is what therapies the patient's on and how does that link up with the insurance. So if we think of Medicare, in the last 3 or 4 years, we've made huge changes in Medicare. It used to be that you had to do 4 finger sticks, which made no sense at all. You had to be in 4 injections, which made no sense at all, because 1 injection is more than enough to do hypoglycemia.
Exactly.
So we know Medicare will pay for all comers, type 1 or type 2, as long as they are on insulin. So that's number one. And if they're not on insulin, but they've had what we call the level 3 hypoglycemia,
Sure.
Right, between 50 and 70, and you can document it, and you've made changes in their therapy, and it occurs again, they qualify, or if they've had 1 assisted low. So that's your Medicare. Medicaid is state by state. Michigan, they have to be on insulin type 1 and type 2. They follow Medicare guidelines. And then the commercial insurance truly is by insurance, but almost every insurance by and far will provide it for anybody on insulin. And then some, like my HMO, if you're on 3 therapies that are not insulin, they will pay for it. So you really have to investigate. Here's the other thing. Sometimes the reason there's no coverage is because the insurance company requires you to use pharmacy, and I've sent it to DME, or they require you to do DME, and I sent it to pharmacy. So if you think it should be covered and the patient is getting denied, just send it the other way. The other thing is coverage is really good. I think the insurance companies have finally come around and said, wait a minute, not only does this help us with lowering A1Cs, get more time in range, less hypoglycemia, but behavior modification. And we've talked about that a number of times. So that is also recognized. So, and what about the cost? So I always say that the cost should be, it's a personal thing. I cannot judge what you can afford, no matter how much you make or whatever you have. That's not my decision. And so sometimes if you don't have coverage, and there's some very good plans that you can, if you're on commercial insurance and you don't have coverage, for $75 a month, you can get 2 sensors. So we can't make judgment. I'm tired of that question. I'm just tired of it, because we can get coverage. People can afford it. We have to ask them if they want to pay cash, if they don't have coverage. And of course, now there are over-the-counter CGM.
I have a great story with that, of a patient who came to me, and I offered a CGM and talked with them about the cash acquisition, because you really shouldn't withhold that prescription.
No.
Because as a provider, it's not going to be covered. And do you know what the patient said to me? Why would the provider make the decision for me without asking me first? And I thought, whoa, really, really good point.
That's my point.
Yeah, absolutely. Okay, let's go in a little bit deeper. So, on this next type of question, do you believe this statement shown on the screen is to be true that CGM technology enhances models of care? I can tell you right now, I can't believe that we would ever think that the Queens wouldn't say anything but yes. But I also want to go to the next question. Why can CGM address social determinants of health? Because it gives that patient immediate insight into their personal health status. And it allows the clinician and the patient to work together to proactively be in their intervention. Thus, what we call enhancing the existing models of care, right? So, Davida, weigh in on your thoughts about how CGM can be an impactful means to directly address social
Yeah.
determinants of health.
Well, I think because if you, first of all, I think going back to the first question is I don't know how you practice without CGM. I don't know how the patients who have people with diabetes live without CGM because the behavior modification, seeing what's happening, seeing the benefits of what's going on. And so if we are not addressing social determinants of health and offering this to people that we are forgetting about, and there may be reasons. I mean, I don't want to put it all on the healthcare providers' shoulders because sometimes, and we'll talk about that in a little bit, sometimes we don't see those individuals as much for a lot of reasons. And then when we do, it may not be offered. So I think that CGM makes the level field,
Yeah,
levels the playing
the
field.
great
Levels the playing
equalizer.
field.
It's the
Right.
great equalizer for sure.
Yes.
Yeah.
Yes.
And you know, I keep coming back to, and I know we said it, but what tends to be that barrier? I think it really sometimes is the clinician who is thinking about it because they're coming top of mind. And for some reason, they talk themselves out of it. And yet we're trying to tell you, wait a minute, come on. Like this can actually bring some of those issues, like you said, for level playing field. And we already have someone top of line talking with us, you know, addressing that said CGM also teaches the person the impacts of foods. Like I've heard it so many times. I know you've heard it. I tell you, one of them was an example of a healthy oatmeal versus a small bag of popcorn. Or we always say that because we think certain foods are healthy, but I can tell you that many of our patients who have been utilizing CGM to see their individual journeys of food, many of them have said, "Oh my gosh, oatmeal hates me," you know,
Yes.
because of
Yes.
the
Yes.
impact of it. Yeah.
And we've got a comment too that, and this is what we're talking about, that CGM also teaches us what foods impact us most.
Yes.
And because it changes behavior, the person with diabetes says, oh, look what happened with one cookie. I don't think I'm going to have the second one, or a portion sizes. So I
Yes.
guess I would even like to flip around that maybe CGM technology enhances existing models of care. Maybe existing models of care enhance technology, enhance CGM because
Exactly.
it's the CGM to me that is the most important component of the existing models of care. And the question is, why are we not offering it to all people with diabetes? And why are we not offering it to older individuals? Older individuals can handle a cell phone. They sure as heck can handle this. And
You
if
bet.
not, someone can help place it for them, and they can see their data. The other thing that I think I see is that the healthcare provider may not be as comfortable with the data coming out of the CGM that you and I might be. And I used to think that, oh my God, we have to teach the world how to use ADP and read all the CGM data. And now I'd love them all to understand that. But today I want them to get out of the way so that
Yes.
all people can have CGM. And if you don't want to use it in your practice, if you're not going to use it to adjust medication, that's fine. The patient only sees you about 40 minutes a year, maybe 30,
Right.
and they
Right.
live with themselves 24 hours a day. And so if I give them CGM, they're now making good decisions and they're managing their diabetes.
I love what you just said because you said something that really came straight to my heart. You said if we're having a clinician who goes, oh, we're only seeing this person 40 minutes a year, but yet they're determining and withholding this ability for the person to engage with their diabetes 24/7. Oh my goodness, you're right, Davida. If we want everybody to be on board, that's why we're here, right? We're here as sugar queens to sweeten it up, to make you feel comfortable with utilizing CGM. But you know what? If you're saying it's not your thing, then by all means get out of the way. And so that greater access to CGM, especially in those underserved populations, age, race, ethnicity, insurance, demographics, we need to start targeting those individuals because they actually might benefit the most from it. So talk to me a little bit about the mobile study.
So the mobile study, which I was an investigator and a co-author, showed that low income and minority populations can be successfully engaged with CGM to enhance their self-management and to improve diabetes control in all kinds of care settings. The CGM improved the outcome A1C by about 1.1% across different racial and ethnic groups, age groups, income, educational. It was 52% ethnically diverse, and 56% had high school diplomas or less. So again, if people don't think the individual with diabetes, the person with diabetes can handle this, they're wrong. They're absolutely wrong. And again, they're making decisions for people that they shouldn't be making. They absolutely shouldn't be making. And also, if they do make these decisions on quarterly visits, the A1C is not going to give them what they need. What we need to do is worry about what transpires in between visits. And if I need to see that data, there's enough data remotely that I can see it. But this study, which was actually a wonderful study, and it's not a new study, so we surely haven't gotten the message out there, really said that we should be much more ethnically diverse in terms of offering these devices, and it's simple enough for all people to use.
Oh, I think for sure. And, to talk about that simpleness, we got another comment in the chat about how maybe one barrier can be that people think they're invasive or they're hard, but they aren't. They're out of the box. They're easy to use. And I think to summarize what we've discussed so far is it really underscores the significant impact that social determinants and racial and ethnic disparities exist. With your mobile study, we showed how they're there. And I think what I want us to be aware of is that we need to try to break down these barriers. And so when we look at that goal of to provide CGM opportunity or access or availability rather to as well, we need to have these things top of mind. And that we really, what's the qualifying criteria for CGM? You have diabetes. That should all be it, right?
That's it. You breathe and you have diabetes. Yes, 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 yes. I mean, every person, you know what I always say, CGM is a right, not a privilege. And every person with diabetes deserves to be wearing a CGM, whatever their walk of life, no matter what, every person should be. And we're not doing a good job. And getting ready for this presentation, realized in my own practice, I need to work on it.
Yeah, because we are human and we're busy and we get things. And so to just pause and to say, why wouldn't I consider this? I also want to bring in the diabetes educators too, because this is a whole team. And it's everything from the prescribers to the PharmDs to the CDCESs. And it really highlights that need for all of us to be on the same page and to be very proactively technology centric. And so, one of the things is you have access to diabetes educators as well. And so tell us a little bit about your practice, how you leverage the team, how everybody's kind of on the same page, and what benefits that is having for your persons with diabetes.
Well, first of all, we are very, very fortunate. Someone had this brainchild, and I wasn't quite sure how it was going to work. I want to say about 15, 17 years ago. And there's a team of diabetes educators. They do all kinds of diabetes education. They do intensive therapy. They talk to people about pumps. They place and teach about CGM and help the patient get ready for all of this, and MNT, you name it. And they're embedded throughout the system. So they have access to these educators in primary care as well as in endo. So they're not seating in our clinic. they're throughout the system. And one of the educators is the head educator to make sure that they're always up on
Wow.
everything, cutting edge. And someone, our division head meets with them once a month, and I get to meet with them in a couple of weeks, and I'm pretty excited about that as well. So they are very well educated. They are in cutting edge. And we know that the benefits of diabetes educated, they're very clear. It shows that their education and their care and the way they manage people with diabetes, help them, give them back, give them the control in their life, is it decreases A1C, it decreases the rates of hospital administration, it improves medication adherence, it increases healthful eating patterns and regular activity, it increases rates of diabetes self-management, and our educators do this by providing diabetes education, CGM education, everything, reviewing the data, but they're giving the power to the person with diabetes, and so they can manage their lives 24/7, because we know this disease is 24/7, and as best I can do. And I answer every message every minute of the day in my in basket, and I'm happy to do that. But at the end of the day, I don't go home with my patients, and they have to feel good about managing it, and that's what diabetes education does for them.
Exactly. And, I urge our listeners to also, if you are so lucky and blessed to have somebody down the hall you can holler at or right next to you, that's great. For me, it's more of a across town kind of thing, but I have a very good relationship with my diabetes educators. They're aware of what we're doing. They actually, one of them got a business award the other day for incorporating CGM and utilizing it for those top of line things we talked about, behavioral. But understand too that we talk about indication for CGM if you have diabetes, but I'm going to, some of the work I'm doing in early diabetes and pre-diabetes, many of them that we now have over the counter iterations that have different features, not intended for those on insulin and such, but they can have big impacts on behavior. And we're getting ready to start a clinical trial for the utilization of, for those with pre-diabetes or early diabetes. And then in addition, I tell you, we're all about advocating. My husband and we're going to DC in a few weeks to advocate for the ADA for the utilization of CGM for pre-diabetes, to open up that coverage for technology, and then to get the whole team together. Because just like with the CDCESs, I know that some areas, and this is where Jen would pipe in, and we could pipe in for her, have PharmDs that are doing that.
Yep.
And those PharmDs are helping with that. They're top of line, front of line. They may be representing both the patient and the prescriber as well, but it's also a team. We're not that we're against each other. We're for each other. We all have our part to play. We all have those things that we are doing related to it. And so CDCESs and PharmDs are just extensions of who we are. And I love that. And that really makes me feel warm in my heart to see us work as a team. So I'm going to transition to our last little topic before we kind of open it up for questions. But, you mentioned earlier, and I can echo this as well, that CGM allows for us to be present with the patient, even though if they're not in the room. In other words, if we are remotely monitoring and telehealth, and how this is a barrier, this is a social determiner barrier for some of these people.
It is.
Talk about that and how you incorporate both the telehealth as well as the no-shows that we all struggle with, for sure.
So, I just want to put in one more comment on advocacy, in case you all don't know, and I think telehealth is very important, probably 50% of the care we provide, and it's getting more and more. And the bill that allows for telehealth to be reimbursed ends December 31st. Now,
Wow.
There is a bill in the House that, of course, that hasn't been front of mind, that needs to be signed. And I urge you all to write to your congresspeople to sign that bill. We've sent a letter around to have every healthcare provider and asking our patients to help as well. So take a minute and just look up your address and send your congressperson and tell them how important telehealth is to the way we practice. And so part of my day is spent, I do clinical research, but I also supervise 7 nurse practitioners, and it's a really nice group. We do 100% diabetes. And I spend some of the time in the in-basket looking at no-show visits, one to fill it and one to see how we can help those individuals. Why didn't they show? Also, what's going on and how often are they no-shows? And it struck me, and I actually brought this up in a meeting because it was kind of overwhelming, is that greater than 90%, and I'm just ballparking this, but it was pretty easy to see, of the no-show visits were people of color. And that just made me feel like we're missing the
Mhm.
ball if that is correct, and it is correct. And why? There's about 1,000 reasons. No insurance lapsed, cannot afford the copay, didn't have a ride. They have to work to feed their family. They could not get the time off. And so even understanding that, because it's easy to say, oh, you've had 2 no-shows, that I'm not going to reschedule you, but to figure out what the answer is. But the importance of the visit may not be realized by that patient either, why we need you to come in and see us. And that does not mean others are not a no-show, but it was very obvious to me that people do not show up for their visits are the ones that need to be seen, and we need to make greater efforts to see these individuals. In my practice, each nurse practitioner has 1 full day of virtual visits. My own practice is about 50% because I'm only in clinic about 1 day a week. However, often those with disparities may not even have a computer. They may not have Wi-Fi or a phone that can manage a virtual visit, but we could reach out to help them to make sure they have access to go somewhere or to somehow use a
Yeah.
family's phone, whatever it is, but we're not doing that. We're making judgment by not judging, by not investigating why these people can't make visits. And then when someone is a face-to-face no-show, one of our MAs will try to reach out to the patient and see if they can contact them and flip it immediately. Like you get them on the phone and say, what happened? Well, my child was sick. Okay, can you
Mhm.
do a virtual visit? Or I couldn't get away. Can you step away and take your lunch hour now? Or when is your lunch break? So that we can make sure that visit still occurs. I worked on a research project offering CGM training nationally. We did this during COVID. It was amazing, through the Cecilia Health Center in Wisconsin. And it was the Helmsley Foundation funded the project. And it effectively was able to reach folks to learn about and use CGM. And that was the total focus of the program that otherwise may not have been offered. The key was virtual care through educators. And we have presented a bunch of abstracts at ADA and AADE with all of the information. So for a lot of people, if we're going to break this barrier, we have to figure out why we're not seeing them. And when we do see them, we need to get them in for visits. But when we do see them, we have to be sure that those individuals get the same kind of care as other patients. I just don't think all of us are doing as good a job as we can.
Lots of opportunity, lots of advocacy. I agree. It starts with us, and we have to identify our own barriers. We're going to transition to Q&A, but I want our listeners, to stop and think. You have challenges that you face trying to initiate and top of mind think of CGM. And so I want us to be real with that. So we want you to get credit for this time. Please scan that QR code so you can get that ongoing credit. Please put your questions and answers. We just have a few more moments to be able to go through those. I love always hearing from you about some of those challenges, because we're here to help you overcome and identify. And as you can see, we are passionate about continuous glucose monitoring and empowering patients to manage their own disease, and also illuminating to us as healthcare providers the problem and the resources, and understanding that we can use these. They're amazing, forward facing to the patient, rear facing to the prescriber on how they improve. And we're getting comments right now about how they are an incredible tool, about their personal response. And it is an incredible tool. And so we want you to go out there and utilize that tool. And we want to help encourage you to identify the barriers and overcome. And again, understand, advocate for that telemedicine. So important for us to continue that, because you live in inner city Detroit, Davida. I live out in a rural area, and so our our touch points are geographical, but your touch points in terms of telemedicine is socioeconomic. And the barrier, whether it's mileage or work, it's still there. It doesn't mean that just geographically is where telemedicine has to be. It's any barrier that prevents them from coming into the office. And fortunately, CGM is perfectly designed for that. So with that, we just so much love you joining with us. We miss Jen, but I anticipate her being with us next time. And we thank you for joining us today and participating in this activity. Remember, hey, Davida, next month, earth-shattering next month. What are we talking about next month, Davida? Ketone
ketones, CGM ketones. Yeah, it'll be very exciting next month. And I want to wish everybody a happy and healthy Thanksgiving.
Happy and healthy Thanksgiving. Thank you so much for joining us. We are the Sugar Queens for our sweet talk. Please join us next month. Be sure to get some of our archived previous programs for ongoing credit. Thank you so much and have a great week and next week with your families.